So, let's dive right in. For all our fellow interventional radiologists listening, today we're unpacking genicular artery embolization, GAE.
Yeah, GAE. It's really becoming quite significant, hasn't it?
It really has. It's turning into, that crucial bridge therapy, especially for knee OA patients who just aren't responding to the usual treatments.
Or those who aren't candidates for a total knee replacement, or maybe just aren't ready for it.
Exactly. It gives them a minimally invasive option, which is huge.
And what's so neat about it, I think, is how it works. It specifically targets that synovial inflammation, the neoangiogenesis, basically going right after the problematic blood vessels.
Right. So the goal for us today in this deep dive is to equip you, our listeners, with, everything you need to know to perform GAE safely and effectively.
Exactly. From the really detailed anatomy, which we have to know cold, all the way to the practical sort of real-world tips and tricks.
Couldn't agree more. And let's start right there with the anatomy, because honestly, understanding this complex network isn't just like academic knowledge.
Oh, absolutely not. It's fundamental. It's your roadmap to avoiding non-target embolization, which is, the big concern.
We're talking about a highly variable system here.
Extremely variable. You've got, 8 main arteries supplying the knee, and they're all interconnected with extensive anastomoses.
So, for example, the descending genicular artery, the DGA, that's a big player, especially in medial OA, right?
That's right. Its osteoarticular branch is very often the target we're aiming for. But then you contrast that with something like the middle genicular artery, the MGA.
Ah, yes, the MGA. Much smaller vessel.
Tiny. But it supplies really critical structures like your cruciate ligaments, and that one you absolutely have to preserve. Embolize that, and you've caused a major problem.
Okay, and this is where it gets, I think, really fascinating, the connections, the anastomoses themselves.
Yeah. Doesn't work.
That link between the DGA and the superior medial genicular artery, the SMGA, you see that in, 85% of cases?
85%. It's incredibly common. And the average size is around 850 microns.
Which is definitely large enough to be a major risk pathway for non-target embolization if you're not careful.
Precisely. And there are others, too, like the connection between the inferior medial, the IMGA, and the medial sural artery. Less common, maybe 5%.
But critical because it's right near the tibial nerve. You absolutely do not want embolic going anywhere near there. That sounds like a sweaty palm moment, as you put it earlier.
It definitely can be. And all this variability, it just underscores why you can't use a cookie-cutter approach.
No way.
It demands a really personalized, precision-guided technique for each patient. We use classifications, like the superior genicular branching patterns or the M1, M2, L1, L2 angiographic types.
To try and make sense of it all.
Exactly. To navigate it safe. It's like learning a complex dance, the basic steps. But every partner, every patient moves a bit differently.
Okay, so we've got the map, we know the danger zones. How do we actually do the procedure? Let's get into the technique, starting with who's a good candidate. Patient selection is key.
It really is. It's your first major decision point. You're generally looking for patients with symptomatic, mild to moderate OA.
And importantly, they need to have failed conservative treatments first.
Absolutely. They have to be refractory to things like physio, injections, NSAIDs, and pre-procedural MRI. It's become pretty essential.
Not just for a baseline picture, right?
No, it's crucial for stratification.
Right.
We're learning more about predictors. For instance, patients with large bone marrow lesions or BMLs or those with severe meniscal tears, they tend not to respond as well.
Okay, so lower Kellgren-Lawrence grades, maybe BML grade 1 or less, meniscal injury grade 2 or less, those predict better outcomes.
That's what the data is starting to show, yes. It helps manage expectations, too.
Makes sense. And patient prep. Anything specific beyond managing anticoagulants?
Well, meticulous anticoagulation management is obviously critical, but also standard prophylactic meds, antibiotics, anti-inflammatories, pretty standard stuff for IR procedures.
And access. What's the preferred route?
Typically, ipsilateral antegrade femoral access is often the go-to. It gives you a pretty direct path.
But you need backups.
Always. You need to be comfortable with retrograde contralateral femoral, which can be better for, say, obese patients. Even radial access is gaining traction, and sometimes pedal access might be necessary. Having options is key.
Okay, so you've got access. Diagnostic angio shows that typical hypervascularity, that sort of tumor blush, we associate with the inflammation.
Right, that's the neovascularity we're targeting.
What's next? Microcatheter selection.
Yeah, then you need to get super selective. A microcatheter, usually a very small one, like 1.7 to 2.4 French, is essential to navigate into those small genicular branches.
And this is where cone beam CT really shines, doesn't it?
Oh, absolutely. Interprocedural CBCT has been a massive step forward. It helps you confirm you're in the right vessel, identifies variant anatomy quickly, maps the territory in 3D.
And significantly cuts down that non-target embolization risk we talked about.
Massively. It turns it into a much more precise, image-guided procedure.
Okay, let's talk embolics. We've got choices, temporary agents like imipenem-cilastatin, IPMCS.
Which has a good track record, especially in some regions.
And then permanent microspheres. What about particle size? That seems to be a hot topic.
It is. There's evidence suggesting smaller particles, particularly those under, say, 100 or maybe even 300 microns. They seem to be linked with more skin issues.
Like that transient cutaneous erythema.
Exactly. Higher incidence lasts longer. So some operators are now advocating for avoiding particles smaller than 300 microns altogether, just to minimize those temporary side effects.
Interesting. And the endpoint, how do you know when to stop injecting?
This is crucial. You're aiming for the resolution of that distal blush, that hypervascularity. But you need to keep the parent genicular artery patent.
So we're not aiming for complete stasis like in, say, tumor embolization.
No, not at all. Think of it more like pruning the abnormal neovessels, not killing the whole tree. Slow, careful injection under fluoro with frequent checks is key to avoid reflux and NTE.
Got it. Pruning, not occluding. Let's shift to complications and safety. Generally pretty safe, right?
Generally, yes. The safety profile is quite favorable overall. The most common thing you'll see is that transient skin discoloration or erythema.
What are the rates like for that?
Around 11-12% overall in some studies, but there's a big difference depending on the embolic agent. Much higher with permanent spheres, maybe up to 63% in some series, versus quite low, like 2.5%, with temporary agents like IPMCS.
Okay, that's a significant difference. What else?
Less common things are, standard access site issues like hematomas, occasionally some transient paresthesia, maybe a mild fever post-procedure.
What about the scary theoretical risk osteonecrosis?
It's always mentioned as a theoretical concern because you are, after all, embolizing arteries supplying bone. But in practice, it seems to be extremely rare. Studies haven't really shown evidence of permanent bone necrosis directly caused by GAE when done properly.
That's reassuring. And good to know it doesn't seem to mess up healing if the patient later needs a knee replacement.
Right, that's another important point. It doesn't seem to compromise future surgical options.
Okay, any final tips or trips for our listeners getting started or refining their technique?
Well, besides really nailing the anatomy and using CBCT, think about maybe using prophylactic IV meds like we mentioned. Some people use radiopaque BB markers on the skin to map the patient's pain location pre-procedure, which can help guide targeting.
Oh, that's clever. Pain mapping.
Yeah, and simple things like maybe an ice pack on the skin beforehand. It can cause some vasoconstriction, potentially reducing skin branch uptake.
Interesting. Any intraprocedural pharmacological tricks?
Some advocate for using intraarterial nitroglycerin. The idea is it might preferentially dilate the target inflammatory vessels while potentially constricting some of the muscle branches, maybe steering the embolic where you want it more effectively.
Worth considering. And post-procedure care.
Pretty standard IR stuff. Good hemostasis, usually a period of bed rest, some activity restrictions for a short while, and just close monitoring for any acute issues. And, of course, long-term follow-up.
Right. Tracking outcomes with WOMAC or VAS scores is essential to see how patients are doing.
Absolutely. You need to know if it's working for your patients.
So, wrapping things up, GAE is clearly a really valuable tool in our arsenal for knee OA. It's this powerful, minimally invasive bridge therapy.
It is. And success really hinges on, as we've discussed, that deep anatomical knowledge, meticulous technique, and leveraging the imaging tools we have, especially CBCT.
That ability to see in 3D makes such a difference.
It really does. And thinking bigger picture, understanding that fine line pruning the bad vessels while protecting the normal ones, avoiding complete stasis that's key for both safety and getting good